Hi students, hope you are all doing good. In this video, we are going to discuss about hyperemesis gravidarum. Okay. Now, we know generally there can be vomiting and nausea in pregnancy, which can occur in about 75% of women. Okay. Now, why this happens? It happens due to the hormone HCG or even due to the hormones estrogen and progesterone. Okay. Usually, normal vomiting in pregnancy starts from say around 5 to 6 weeks. Okay. Then it will peak around some 10 weeks, and later on gestations, say when she enters 16 weeks and all, it will fall. Okay, so the number of episodes will fall, and usually there will be a baseline after which she won't have any vomiting. Okay, but in some cases, around say 15 to 20% of the cases, okay, this vomiting can be seen till her third trimester also, and in some cases, say 5% of cases, this can be seen even till her delivery also. Okay. Now we will see what is hyperemesis gravidarum. Hyperemesis gravidarum is usually defined as an excessive vomiting in pregnancy. Okay. It is not related to the gestational age, it is related to the number of episodes and the complications. Okay. See, most commonly, okay, we use these criteria to define a hyperemesis gravidarum, which will include, say, there is severe nausea and vomiting, and there is a weight loss, okay, around some 5% of her pre-pregnancy weight. Okay, or in kgs, this can be around some 3 kgs of weight loss also, and there can be ketonuria also. Okay. There is another set of criteria, which is the international criteria used for defining hyperemesis gravidarum. Okay. Those include severe nausea and vomiting. Okay. That is, the patient is unable to eat or even drink anything, okay, due to this excessive vomiting. And her routine life is affected. Okay, say her quality of life is affected, and this should begin early in pregnancy, means at least before 10 weeks. Okay, so this is how we define the hyperemesis gravidarum. Now, in hyperemesis gravidarum, the recurrence rate can be around 15 to 20%, and we will now see some risk factors, okay, of hyperemesis gravidarum. So, what are some of the risk factors? Number 1, when she is a young age woman and then it is her first pregnancy, that is, she is a prime gravida. Then if it is a multifetal pregnancy, okay, and there is any genetics relation, suppose her mother or her sister had history of hyperemesis gravidarum, and it is more when she is carrying a female fetus, and hyperemesis is more in case of molar pregnancy, and it is also associated if she already has a history of motion sickness or migraine. Okay, so it is easy to remember. You have to just think the conditions in which beta HCG is going to be high. Okay, in young age and primary gravida, it is the first time exposure to beta HCG during pregnancy. Okay, so that is the reason. Okay, now we'll see about pathophysiology. First point is about the hormonal changes, as we have already discussed. Okay, so again it is about the beta HCG, not beta HCG, it is about the HCG hormone. Okay, so that's why in multiple pregnancy and molar pregnancy and all, where there is increased levels of HCG hormone, there is going to be more hyperemesis chances. And what are the other hormones that are also having a role? It is estrogen and progesterone hormone. Why? How estrogen and progesterone contribute? Because they will be causing the lower esophageal sphincter relaxation. Okay, so that will lead to a state of gastric esophageal reflux disease, which can be associated with vomiting. Okay, that can be increased vomiting. Okay, now we will see some genetic factors. Now we will see about the genetic factors. Okay, two genes are associated, namely GDF15, that is growth differentiation factor 15, and IGF BP7, that is insulin like growth factor binding protein 7. Okay, and not only this, you have to keep in mind about the hepatic causes, okay, or dysfunctions, infections, okay, and also the psychological factors. Understood? Now, how can we classify Hyperemesis gravidarum? Classification is based on PUQE score. Okay, so what is PUQE? It is pregnancy unique quantification of emesis. Okay, so based on this, there are three classes. Either it can be mild, moderate, or severe hyperemesis. Now, how we are going to calculate the score? Okay, we can calculate the score by asking the questions like, for example, in the last 24 hours, okay, did she had any nausea, okay, or did she had any vomiting, or any history of retching was present. Okay, so these three symptoms are asked and it will be given a score between 1 to 5. Okay, you can classify them into mild, moderate and severe. When the score is less than 6, it is mild, and when the score is between 7 to 12, it is moderate, and if the score is between 13 to 15, usually it is a severe hyperemesis gravidarum. Okay, so no need to know about the detailed things about this classification. You just know it is classified into mild, moderate and severe, and the 3 parameters or the 3 questions we are asking is about the nausea, vomiting and retching, right? Now, a patient comes and you are going to examine her. Okay, first one is examination always. Okay, so you have to examine her. What and all you will examine? You will be looking for the vitals. Yes, see, blood pressure, pulse rate, her temperature. Okay, then about her respiratory rate also. Then it will be her oxygen saturation. Okay, you will be doing a check on her weight as well as abdominal examination. Okay, and don't forget to look for any signs of wasting or dehydration also. Clear? Yes. Now, what are the investigations you want to send in this case? Okay. So, the investigations what I want to do will be, first one, urine dipstick, okay, to look for any ketonuria. Then you can, that can be done even by collecting a midstream urine sample, okay, and you have to do a full blood count, okay. Okay, and you have to check if there is any infection, okay, or for example, if there is any H. pylori that is going to cause a GERD, okay. Then you also have to check her hematocrit, because hematocrit increases, okay, in dehydration. Then you have to check the urea and electrolytes also. There can be electrolyte abnormalities like hypokalemia, hyperkalemia or hyponatremia, okay, and we have to rule out other causes of ketonuria and ketoacidosis. For that, it is advisable to do a blood glucose test also. Now finally, last but not the least, you have to do a ultrasonogram also to make sure that it is an intrauterine pregnancy. Okay, to confirm your intrauterine pregnancy, you have to exclude on multiple pregnancies as well as rule out your molar pregnancies also. Okay. In some refractory cases, there can be an additional need to do a thyroid function test to check whether she is a hypothyroid or a hyperthyroid. Then do her LFT, because you have to rule out other causes of vomiting also, to rule out hepatitis or gallstones, okay, and serum amylase can also be done to check if there is a pancreatic cause, okay. Then acid base analysis should be done to rule out any metabolic disturbances, okay. Okay. Now generally if you take Hyperemesis gravidarum, it is associated with, as I have told you, it is hyponatremia, hypokalemia. Not only that, there can be low serum urea, hematocrit can be risen. So there can be ketonuria. Because of vomiting, there can be hypochloremic alkalosis, and sometimes in severe cases there can be metabolic acidemia also. Okay, so this is the summarization of all the report findings you will get in Hyperemesis gravidarum. Okay, next we will see about some of the differential diagnosis. Okay, so if the vomiting is persisting even after 16 weeks, okay, you should rule out other causes of vomiting also. Okay, so these include, say for example, peptic ulcers, which are a cause of GERD, then cholecystitis, then hepatitis, and even pancreatitis.